disease. We've got 9 questions to go through, and we'll go through hyperthyroidism, hypothyroidism, how to manage them both, some causes of both, and then we'll also go through some stuff about thyroid lumps, so masses that you might find on the thyroid, and we'll finish with thyroid cancer as well. So let's get straight into it. So question number 1, a 55-year-old man is reviewed on the general medical ward after stepping down from intensive care. He was admitted 1 week ago with the community-acquired pneumonia, requiring intensive care admission due to his hypoxia. He has asthma and is a smoker. He is currently tachycardic with a heart rate of 100, so his thyroid function tests have been requested. On admission, his thyroid function tests were normal. He feels well and has no sweating, tremors, weight loss, diarrhea, or heat intolerance. Blood results are as follows. Which of the following is the most likely explanation for these laboratory findings?
Okay, so we're halfway through. Pop your answers in if you haven't already.
So the answer for this one is sick euthyroid syndrome. And I'll take you through why that's the case. So he's, this is a man who's come into hospital with normal thyroid function when he was admitted. And he suddenly, after a week of being very unwell and requiring intensive care, has now become, his thyroid function has changed. And if we look at the thyroid function test, we've got a low TSH and a low T4 and a low T3. So everything is low. And he's got no symptoms at all at the moment of thyroid disease. So when everything is low and we know a patient's been very unwell, that typically tends to be something called sick euthyroid syndrome. And basically what that means is the patient is symptomatically euthyroid, but all of the thyroid function tests, so the TSH, the T4 and the T3 are a little bit suppressed. If this were primary atrophic hypothyroidism, we would see a low T4 and T3, but the TSH would be much higher, whereas here the TSH is low. And in Graves' disease, de Quervain's thyroiditis, and toxic multinodular goiter, we would see symptoms of hyperthyroidism. I thought I'd start with a question about general interpretation of thyroid function tests, because that's really important. It's really important to understand the negative feedback pathway, and also in order to be able to diagnose different thyroid disease. So this is a pathway that I'm sure you've all come across before. The hypothalamus secretes thyrotropin releasing hormone, which stimulates the anterior pituitary to secrete TSH, and TSH works on the thyroid gland to produce thyroid hormones, and that takes up thyroglobulin and takes up iodide ions to make the T3 and T4. T3 is the active version of thyroid, and 85% of T3 is formed by peripheral conversion of T4 to T3, and the rest is made in the thyroid gland. And T3 and T4 both have negative feedback on the hypothalamus and on the anterior pituitary. So if there is a really, really high level of T3 and T4, that will feed back negative, and well, that will have a negative feedback mechanism on the anterior pituitary. So the TSH will go down to try and reduce the amount of T3 and T4. So this is summarised in this table here. If we look, first of all, primary hypothyroidism. Primary means the problem is in the thyroid. Secondary means the problem is elsewhere. So in primary hypothyroidism, you get really high T3 and T4, and there's negative feedback, so you get a low TSH. In secondary hyperthyroidism, as I said, the problem is elsewhere, and that's usually either the anterior pituitary or the hypothalamus. So then you get high TSH, and so there's probably usually due to a TSH secreting tumour, lots and lots of TSH being secreted, so then you get high T3 and T4. And then there's also something called subclinical hyperthyroidism, which is where you have a low TSH, but a normal T3 and a normal T4, and you don't have any symptoms. And then if you go on to hypothyroidism, primary hypothyroidism, again, primary means coming from the thyroid, so there's low T3 and T4. And because there's low T3 and T4, there's less negative feedback onto the anterior pituitary, so your TSH goes up. Secondary hypothyroidism means there's a problem elsewhere, so up in the anterior pituitary or the hypothalamus, and that means, and here it's producing much less TSH. Less TSH means less T3, T4 secretion. And then subclinical hypothyroidism is again asymptomatic, subclinical, and you have a high TSH but a normal T3 and T4. And we'll come to some of those later. And then there's this sick euthyroid syndrome. And in sick euthyroid syndrome, as I said, everything is low, TSH, T3 and T4. And that's just, it's not 100% clear the mechanism of sick euthyroid syndrome. It's just where it's often where a someone's been in hospital or someone has a chronic disease and they've got no symptoms of thyroid disease, but their T3, T4 and TSH are a little bit low. Usually, to manage these people, we would repeat the thyroid function when they're better or in a couple of months' time to see if it's changed at all. Question 2. A 35-year-old woman presents to the emergency department with a 1-month history of worsening weight loss, diarrhea, and heat intolerance. She has no past medical history. Currently, she is slightly agitated but not confused and has a fine tremor. Her observations are as follows: heart rate 120, temperature 39, blood pressure 130/70, saturation is 98% on room air, and respiratory rate 24. And you can see the blood results here as well. Supportive management is started with IV fluids and paracetamol, and she's commenced on propranolol to help control her heart rate, and she's referred to critical care. Which of the following is the next best step in the management of this patient?
Halfway through on the poll, if you pop your answers in if you haven't yet already.
Great, so most people were right in that one, and it's administer a thionamide. And a thionamide is either carbimazole or propylthiouracil, or PTU, and those are both things that reduce inhibit thyroid hormone synthesis. So this is a case of a young woman, no past medical history, and she's presented with typical features of hyperthyroidism. And her blood tests also show the typical classical features of primary hyperthyroidism, which can be due to a few different things, which we'll cover shortly. But given her symptoms, she's tachycardic, she's got a really high temperature, she has a fine tremor, so she's clearly got thyroid toxicosis. And thyroid toxicosis, when it starts to cause organ dysfunction, can result in what's called a thyroid storm. And with that, you can get things like, the main thing you need to account for is heart failure. So the main principles of treating a kind of thyroid toxicosis, thyroid storm, as well as supportive care, so we've started IV fluids and paracetamol in this lady, there are kind of three main principles to caring for these patients. The first one is that we need to block thyroid hormone synthesis as soon as possible. So we need to target the thyroid gland directly, so that's with either one of carbimazole or PTU, propylthiouracil. Carbimazole is, comparing these two together, they have fairly similar efficacies. PTU works a bit quicker and also has the benefit of blocking the peripheral conversion of T4 to T3, but PTU can cause, has the potential to cause liver toxicity, whereas carbimazole doesn't cause liver toxicity. Second principle is to prevent further thyroid hormone release. So as well as blocking thyroid hormone synthesis, we want to stop its release. And to do that, you can give something called Lugol's iodine. And this is basically giving an iodine load. And there's something called the Wolff-Chaikov effect, which I've written there. And that's basically the mechanism, again, not hugely well understood, by which when you inject a large amount of iodine into the body, it actually inhibits the thyroid gland. It prevents the thyroid gland from releasing more thyroid hormone. It kind of stops the thyroid gland from making thyroid hormone because it thinks there's already a lot of thyroid hormone in the body because of the iodine that you've just given. But this is usually administered after you've administered the thionamide, so the PTU or the carbimazole, after 1 hour. And then the third kind of principle here is to inhibit the peripheral conversion of T4 to T3. As I said earlier, the T3 is the active version and T4 is inactive. And there are a few things that can prevent the conversion. So steroids inhibit the peripheral conversion of T4 to T3. Propranolol, which is quite a good one to give if patients are tachycardic. And PTU can also inhibit the peripheral conversion. And then, as I said before, supportive care is really important. So that's things like IV fluids, antipyretics like paracetamol, beta blockers like propranolol, and then making sure patients have good nutritional support and making sure electrolytes are optimized. And it's important to get critical care involved early in all of these patients. And on the left there, I've just left a kind of picture of some of the signs and symptoms that you see in hyperthyroidism. So there's also another thing to remember. Aspirin and salicylates are associated with displacement of thyroid hormone from thyroxine-binding globulin. Thyroxine-binding globulin attaches to thyroid hormone and basically stops it from functioning. So if you have aspirin, you need, in hyperthyroidism or thyroid storm, you need to avoid aspirin because aspirin prevents that binding and inhibition of thyroid hormone. Question 3. A 45-year-old woman presents to the GP with a 1-month history of weight loss, diarrhea, and worsening tremor. She also reports discomfort in both eyes, but no other visual symptoms. She has past medical history of vitiligo and type 1 diabetes. On examination, she has exophthalmos, lid lag, a fine tremor, and pretibial myxedema. Which of the following investigation findings is most consistent with the most likely diagnosis?
And you're halfway through. If you pop your answers in, if you haven't already.
Excellent. So that's about 54% of people got the right answer there. So it's the presence of anti-TSH receptor antibodies. So this is a case of Graves' disease. So it's, again, a young woman with a background of autoimmune disease, has presented with symptoms of hyperthyroidism, and the fact that she has exophthalmos and pretibial myxedema points towards the diagnosis of Graves' disease. And in Graves' disease, it's really important to look at the different kind of blood results. So the reason it's not A is that in Graves' disease, you see hyperthyroidism. So you'd see a high T4 and T3 and a low TSH. You get a smooth goiter on ultrasound scan instead of a multinodular goiter. And you get increased uptake of iodine on a radioisotope scan instead of decreased. And that's why the answer is anti-TSH receptor antibodies. So Graves' disease is basically caused by circulating IgG autoantibodies that bind and stimulate the TSH receptor. And then that causes increased thyroid hormone synthesis and thyroid enlargement. As I was saying before, the signs associated with Graves' disease are the usual signs associated with hyperthyroidism. And then there's two signs that are very specific to Graves' disease. So exophthalmos and pretibial myxedema are both due to the TSH receptor autoantibodies, the circulating autoantibodies. And that's what causes this kind of painful exophthalmos. So if you see those in an examination, then Graves' disease is the most likely cause of the hyperthyroidism. And the antibodies associated with Graves' disease are most likely to be the TSH receptor, which is found in 90% of patients with Graves' disease. And then you can also find thyroid peroxidase and thyroglobulin antibodies as well, but less likely to be associated. And in patients with Graves' disease, the management is similarly to with the thyroid storm. We wanted to start carbimazole or PTU, a thionamide, quite quickly. So that's your first line of management, to start a thionamide. And you can either titrate the dose up or slowly until you see the thyroid hormone level come back into normal range. Or you can do the block and replace, which is where you completely block with carbimazole or PTU, give them a big dose, and then you give them replacement with levothyroxine. If after that therapy you relapse, you can also have radioiodine, which is where you give patients radioiodine, which gets taken up by the thyroid, and then because of the radioactivity of it, it prevents the thyroid from creating thyroid hormone. And if you have a large goiter that's causing airway compromise, or if you're pregnant and you can't take thyroid hormones or radioiodine, or in cancer, or if for patient choice, you can have a thyroidectomy as management of Graves' disease. But first line is the thionamides, carbimazole or PTU. And it's important if we are giving patients carbimazole to look out for agranulocytosis, which is a rare but fatal side effect of carbimazole. So if anyone ever comes in with, if anyone ever who's on carbimazole has a fever or even has symptoms of a cough or cold, it's important to look at their white blood cells and see if they've got agranulocytosis very early. And if they do, then it's important to stop the carbimazole as soon as possible. Question 4. A 35-year-old woman presents to the GP with a 1-week history of palpitations, as well as feeling hot and sweating more than usual. She reports some flu-like symptoms 2 weeks ago, which self-resolved after 2 days. On examination, she is tender on palpation of her anterior neck. Her blood results are as follows. A thyroid radioisotope uptake scan shows reduced uptake of the radioisotope. Which of the following is the most likely diagnosis?
Okay, and we're halfway through.
Excellent. So the answer to that one is de Quervain's thyroiditis, and de Quervain's thyroiditis is a post-viral thyroiditis. The clues in this question are that this is a young woman, again, with no past medical history. She has had a recent flu-like illness, and she has a painful anterior neck. So de Quervain's thyroiditis is painful. And as you can see from the blood results, again, this is a picture of primary hyperthyroidism, high T4, high T3, and a low TSH. In thyroiditis, you often see a period of hyperthyroidism, and then you can see it goes into hypothyroidism after that. And the thyroid radioisotope scan shows reduced uptake, which is typical for a thyroiditis. In Graves' disease, we would expect an increased uptake of the radioisotope. And in Riedl's thyroiditis and Hashimoto's thyroiditis, we would see a picture of hypothyroidism on the blood tests instead of hyperthyroidism. And we wouldn't have the painful palpation on the neck. So in terms of thinking about what's some causes of hyperthyroidism, Graves' disease, as we've already spoken about, is quite one of the most common causes. And it's important to look for the eye disease and look in the blood test for the TSH receptor antibodies. De Quervain's thyroiditis is post-viral, and you have a painful neck. So those are the 2 clues to look for in a question. A toxic adenoma is when you have a solitary nodule somewhere in your thyroid gland, which is toxic, and toxic just means that it's secreting thyroid hormone. You can have a toxic multinodular goiter. That's where you have a goiter, so an enlarged thyroid gland, which is multinodular, so has lots of nodules on it, and is toxic. So one of the nodules or multiple nodules will be secreting lots of thyroid gland. And you can see those often more so in elderly people or in iodine deficient areas. So more common in countries that aren't the UK, like developing countries. Ectopic thyroid tissue, so you can see ectopic thyroid tissue in teratomas, for example, or in metastatic follicular thyroid cancers, where you can get spread of the follicles. and exogenous use, so when patients are abusing levothyroxine, for example, to try to lose weight or something like that. And the way that you can tease exogenous levothyroxine excess from endogenous hyperthyroidism is to look at the thyroglobulin. And in exogenous levothyroxine excess, because of the negative feedback pathway, and because you're not synthesizing lots and lots of thyroid hormone, you see a low thyroglobulin. Whereas in endogenous hyperthyroidism, you see a normal or high thyroglobulin. And the radioisotope uptake scan is a really nice way to differentiate between different types of hyperthyroidism. And I've got this image here of different types of different causes of hyperthyroidism and what they do. So as I said before, Graves' disease you see an increased uptake of the radioisotope. In toxic multinodular goiter, you get increased uptake in some areas, more increased in some areas, slightly increased in some areas, not so much in other areas. If you have a toxic adenoma, you have a significantly increased radioisotope uptake in one area and reduction in uptake in the other areas. And in thyroiditis, you tend to see a reduction in uptake of the isotope. So you would see what you see here in E. And these scans can be used in the investigation of hypothyroidism if you've not got a diagnosis. And they can also be used post-thyroidectomy to see if there's any residual tissue that you've not removed when you've done your thyroidectomy. So question 5, a 65-year-old woman presents to the GP with a 2-month history of lethargy, constipation and weight gain. She reports that she's been quite low in mood. She has a history of pernicious anemia and type 1 diabetes. On examination, she has conjunctival pallor, brittle hair, and a smooth, painless goiter. Blood tests are as follows. Which of the following is the next best investigation to confirm the most likely diagnosis?
And you're halfway through.
Excellent. So the right answer is thyroid peroxidase antibodies. So this is a 65-year-old woman who's presented with signs and symptoms consistent with hypothyroidism, and her biochemical findings are also consistent with primary hypothyroidism. She has a painless goiter, and she has a history of autoimmune disease, which points us towards an autoimmune cause, and the most common autoimmune cause of hypothyroidism being Hashimoto's thyroiditis. And the antibodies most associated with Hashimoto's are thyroid peroxidase antibodies. TSH receptor antibodies are seen in Graves' disease, which we've already discussed, and that would present with hyperthyroidism. Serum thyroglobulin, we tend to send off to look for specific types of cancer, which we'll come on to later. Ultrasound of the thyroid gland is always helpful when there's a goiter, but it won't give us the diagnosis. An MRI brain is only really necessary if we're suspecting a pituitary problem. But here it looks like primary hypothyroidism. So we're expecting a thyroid problem instead of a pituitary problem. Here's a picture of some of the signs and symptoms of hypothyroidism. So like we saw in the question just now, it's things like fatigue, weight gain, feeling cold. it can affect lots of different body systems. So constipation, menorrhagia, it can cause very kind of cold extremities, and it can cause bradycardias. And some of the different causes of hypothyroidism, by far the most common cause in the Western world is primary atrophic hypothyroidism. And that's basically just caused by kind of a diffuse lymphocyte infiltration of the thyroid gland, which causes atrophy. So the thyroid gland shrinks it, and so you don't get a goiter where the thyroid gland enlarges. Much more common in women, and that's by far the most common cause of hypothyroidism. Now thinking about the autoimmune cause of hypothyroidism, Hashimoto's thyroiditis, which we've just covered in this question. It's autoimmune. You get lymphocyte and plasma cell infiltration into the thyroid, which causes a goiter, painless goiter. Antibodies associated here are thyroid peroxidase antibodies, which are seen in about 90% of patients with Hashimoto's, and thyroglobulin antibodies, not serum thyroglobulin antibodies, which are seen in 80% of patients with Hashimoto's. Other causes of hypothyroidism, the most common cause worldwide of hypothyroidism is iodine deficiency. As I was saying before, that's very unlikely in a country like the UK, because in the Western world, food tends to be, some foods are fortified with iodine. And then other causes are things like post-thyroidectomy, if you're not replacing your thyroid hormone effectively. And treating hypothyroidism is fairly straightforward. You just give thyroid hormone. So levothyroxine is thyroid hormone, or T4, and then that will be converted to T3 in the periphery. You can start on a dose of 50 to 100 micrograms once daily, and then you can check the TSH after 6 weeks of changing the dose, and also assess the clinical stage to see if the patient is still symptomatic or not. And then you can modify the dose based on the patient's clinical state and the TSH. In elderly patients, it's better to start at a slightly lower dose, so 25 micrograms once daily. And it's important not to try to, we need to be aware of things like angina and MIs. Levothyroxine can increase your risk of AF, and it can increase your risk of osteoporosis. So it's important that we don't over-treat people. Question 6. A 68-year-old man presents to the GP with a 2-month history of worsening tremors. This is associated with weight loss of 3 kilograms, diarrhea, and heat intolerance. He was discharged from hospital 6 months ago, where they had started several new medications following a myocardial infarction, complicated by ventricular arrhythmias. He has a history of rheumatoid arthritis. Blood results are as follows. Which of the following medications is the most likely cause of this patient's symptoms?
And just over halfway through.
Great, so the answer to that one is amiodarone. So when we're thinking about thyroid disease, it's important to think about medications that might be causing thyroid disease. And amiodarone is a very important one of those. So if we're starting amiodarone therapy on anyone, we need to have their thyroid function tests, tested regularly if they're going to be on long-term amiodarone. Other medications that can interfere with thyroid hormones, glucocorticoids, so steroids, and we've previously mentioned that steroids can be used to prevent conversion of T4, peripheral conversion of T4 to T3. And it's important to remember that. So if we're giving someone steroids, we're inhibiting their T4 to T3 conversion. Other medications that can cause thyroid disease, and this can be hyper or hypothyroidism, are mentioned on the list here. And amiodarone basically causes hypothyroidism because amiodarone is very iodine rich, so it provides an extra iodine substrate for thyroid hormone synthesis. So as I said, it's important to monitor thyroid function if we're giving a medication that could cause thyroid disease, and we tend to do that every 3 months. And if a patient already has thyroid disease, such as Graves' disease or some form of thyroiditis or anything like that, it's really important that we are really cautious and bear that in mind, and maybe try them on a slightly different agent, a slightly different medication that won't cause thyroid disease. In a patient like this where thyroid disease has occurred due to the medication, we would want to stop the medication as soon as possible. So we would discuss with the team that started the medication, so for example in this case the cardiologists, and see if they're happy for us to stop the medication and change it to a different one. Question 7. A 57-year-old man presents to the GP for a routine health check and blood test. He has a history of hypertension, which is well managed with ramipril, 5 milligrams once a day. He works in an office, and apart from some stress at work, he's been feeling well and reports no abnormal symptoms. Physical examination shows no abnormalities, and blood results are as follows. So hemoglobin is 135, white cells 5.4, platelets 273, bilirubin 10, ALT 24, ALP 76, urea 6.4, creatinine 86. TSH is 5.9, free T4 is 15, and free T3 is 5.6. Which of the following is the next best step in the management of this patient?
And we're halfway through.
Excellent. So the answer is repeat thyroid function tests in 3 months. So this is okay. This is something that we come across quite frequently, actually. This is an asymptomatic patient who has normal thyroid hormones, so normal free T4, normal free T3, and a slightly elevated TSH. If he had hypothyroidism, we would see an elevated TSH, but we would see low T4, low T3, but T4 and T3 are normal here. And he's completely asymptomatic. So this is called subclinical hypothyroidism because of him being asymptomatic. This is quite common, as I was saying, we see it quite a lot, and it can occur in about 10% of those people over the age of 55. And basically, it's important in these patients to take a really thorough history, ask about any symptoms of hypothyroidism. If it's a woman of childbearing age, ask about potential pregnancies, because these results can occur in pregnancy, and ask about any autoimmune diseases. And then we would probably just check it again in 2 to 4 months. So check the TSH, check the T4, and check the T3 in a couple of months. And if the TSH is still elevated after a couple of months, we could consider sending the autoantibody screen. So the thyroid peroxidase antibodies, TSH receptor antibodies, and thyroglobulin antibodies. Those are the 3 important antibodies to remember in thyroid disease. And in terms of which patients to treat with levothyroxine and which ones not to treat, it's a difficult decision, and ideally it would be discussed with an endocrinologist or a specialist. But if anyone has any hypothyroid symptoms, then it's worth starting them on levothyroxine treatment. If anyone has positive autoantibodies, they should be started on treatment. If anyone's got a really high TSH, so TSH above about 10, it's worth starting on treatment. And anyone who's pregnant or trying to conceive, it's worth starting on treatment. It's just important to remember that if we ask that over-treating patients can increase the risk of AF and osteoporosis, as I mentioned before. Question 8. A 65-year-old lady presents with a 3-week history of weight loss despite increased appetite, diarrhea, and tremors. She reports feeling hot all the time. She has a history of type 2 diabetes, managed with metformin, 500 milligrams twice daily, but is otherwise well. On examination, she's tremulous, appears sweaty, and has a regular heart rate of 75 beats per minute. She has a single palpable lump in her anterior neck that moves on swallowing. She has no hoarse voice and no stridor. A radioisotope scan shows increased uptake in one area of the thyroid gland with suppressed uptake in the rest of the gland. Which of the following is the next best step in management of this patient?
Halfway through.
Yeah, so this is quite a difficult one. The correct answer is radioiodine therapy. And I'll go through why. So this is a lady again who was presenting with symptoms of hypothyroidism. She's got a radioisotope uptake scan which shows increased uptake in one area of the thyroid gland. So it's probably a toxic adenoma or a toxic thyroid nodule. And that's what we want to be treating. In terms of the different options, propranolol isn't worthwhile, probably isn't going to help because her heart rate is fairly remarkable. She is tremulous, so it might help with that, but the heart rate is normal. So we need to be careful with beta blockers, given the heart rate. Carbimazole and propylthiouracil are good shouts. They're reasonable suggestions, but the first line option in a patient like this, where they have really increased uptake in one area of the thyroid gland, is radioiodine therapy. And I'll go through that in a second. So in terms of different types of thyroid lump, when you're thinking about thyroid lumps, first of all, it's important to think, is the thyroid smooth or is the thyroid nodular? And then it's important to think about the patient. Is the patient hyperthyroid, hypothyroid, or euthyroid? So in terms of a smooth thyroid or a goiter that's non-toxic, so the patient isn't hyperthyroid, the most common cause of a smooth non-toxic goiter is iodine deficiency. Hashimoto's can also cause a smooth non-toxic goiter. And you can get a smooth non-toxic goiter in pregnancy, so physiologically. If you have a smooth goiter that's toxic, so causing hyperthyroidism, that's either Graves' disease or the early phases of de Quervain's thyroiditis. And Graves' disease tends not to be painful on palpation, but de Quervain's thyroiditis is painful on palpation. If you have multinodular goiter, you can, so multinodular goiter, quite common in the UK in terms of thyroid lumps. And if you, in terms of patients who present with a single nodule, about 50% of them have a multinodular goiter. And as I said before, sometimes one of those nodules can become toxic, and that will show up on the radioisotope scan. And then you have single thyroid lumps. So this case was a single thyroid lump, and that could either be a thyroid cyst, an adenoma, a carcinoma, or a discrete nodule of a multinodular goiter. So as I said, a nodule that you think is a single nodule, and then you realize it's actually part of a multinodular goiter. When you detect a lump, there are a few investigations that it's important, or, well, when you detect a lump or a goiter, there are a few investigations it's important to organize. Really important to get thyroid function tests. It can be helpful to get a radioisotope uptake scan. As we've already seen, it can elucidate different causes of uptake on the scan. And it's also important to get an ultrasound scan of the thyroid gland to further characterize the lump and see if there are any other lumps. If you're concerned about cancer, you can get cross-sectional imaging of the neck and the chest. So a CT scan, for example, of the neck and the chest. And if there is a lump there that you think might be amenable to a fine needle aspirate, then this is a really good way to get some samples for cytology to send it to see if it is cancerous or not. When you do have a lump there in your thyroid, if you do have a thyroid lump, if it's toxic, so if it's causing hypothyroidism and if it's got increased uptake on a radioisotope uptake scan, the first line of the therapy is radioiodine. And that's because radioiodine will be immediately taken up into the lump. So will prevent further thyroid hormone synthesis and secretion. If radioiodine is contraindicated, then you can give antithyroid drugs. So radioiodine is contraindicated in pregnant women, in thyroid cancers, and when you have thyroid eye disease. And if there's any airway compression from the goiter or the lump in the thyroid, then a thyroidectomy is required urgently. So final question, question 9. A 45-year-old woman presents with a 2-month history of a lump in the anterior part of her neck, along with weight loss of 3 kilograms. She has no past medical history. She reports a family history of pheochromocytoma and thyroid cancer. An ultrasound scan shows a solitary nodule within the thyroid gland, from which a fine needle aspirate is taken and sent to the lab. Blood tests demonstrate an elevated calcitonin and a normal thyroglobulin. Which of the following is the most likely diagnosis?
Just over halfway through.
Excellent. So medullary thyroid cancer is the correct answer. And we'll go through each of the cancers now, but the main clues in this question are that she has a family history of pheochromocytoma and thyroid cancer. And in terms of family history of pheochromocytoma, it's important to think about the MEN syndromes. And MEN2 has an association between pheochromocytoma and medullary thyroid cancer. And the fact that she has an elevated calcitonin, so the elevated calcitonin points towards medullary thyroid cancer as well. So in terms of the thyroid cancers, there are 4 that it's important to remember. And also maybe a 5th, being thyroid lymphoma, but that's kind of a lymphoma that can infiltrate the thyroid and cause a thyroid lump. So it's important to have the lymphoma in the back of your mind. But the 4 most common thyroid cancers, papillary is the most common, often presents in younger people, women more often than men. It has a very good prognosis. It usually spreads to the local nodes first and then spreads on after it spreads to the local nodes, and it can spread to things like the lungs. And in terms of monitoring treatment response, we usually measure thyroglobulin. So thyroglobulin can be elevated initially, and then as patients respond to treatment, the thyroglobulin goes down. Follicular thyroid cancers, the next most common, tend to occur more in the middle-aged, and in comparison to papillary cancers, they spread earlier in the blood to the bone and to the lungs. And again, with them, we can measure thyroglobulin. Sometimes it could be a follicular adenoma, sometimes it can be a carcinoma. And in order to tell between them, it's difficult to tell between the 2 of them on an FNA or on an FNA because it's such a small sample and the histology looks quite similar, and it's all about whether it's invaded the capsule. So the thyroid lobectomy is important to differentiate between the 2 of them. So if you have any suggestion of follicular histology on an FNA, then the patient will be referred for a thyroid lobectomy so that they can see if it's adenoma or carcinoma. The next most common is medullary, which was the right answer in this case. Now, the majority of medullary thyroid cancers happen sporadically, but about 20% of them are associated with MEN2, which is what I was talking about just now. And this is a cancer of the parafollicular cells in the thyroid gland, or the C cells, and they're the ones that secrete calcitonin. So that's why we measure calcitonin. And if we look over to this image here, this kind of gives a demonstration of MEN1, MEN2A, and MEN2B. And in MEN2A and 2B, there's an association between medullary thyroid carcinoma and pheochromocytoma. So although it's incredibly rare, it's still important to remember those, as it's kind of a classic exam type question to throw those in as part of the family history. And the most rare type of thyroid cancer is anaplastic. Tends to present in the elderly, very aggressive, spreads very early, very poor prognosis. And that is the end of the lecture. So